Hello, this is Carlo Martuscelli joining you once again. I'm a health reporter for Politico Europe, and today, hello, hi. Yeah, no, please sit. Yes, you can sit. I'll introduce you in just a second. Today we'll be discussing cancer and other non-communicable diseases back on the EU's radar. The COVID-19 pandemic has supercharged the EU's health efforts. The Commission's budget for its health program has gone up tenfold, and we've had a frenzy of lawmaking activity from Brussels on the health union files, HERA, and of course, the cancer plan. At the same time, we know that the coronavirus has put health systems around the EU under severe strain, not just because of the hundreds of thousands of people falling sick, but also because all of the resources diverted away from usual care. We know there's been a huge amount of missed cancer diagnoses, but it's not just cancer, it's also people living with other non-communicable diseases that have had their usual courses of treatment interrupted. Hospitals now are working through the backlog, but once again, we have new waves of COVID that are building up, and health services that were already stretched pre-pandemic are even more stretched. Policymakers now have to have one eye to the recent past on all of those missed appointments and all those hospital visits that never took place, and one eye to the future, to think about how Europe's different and at times divergent health systems can be made more resilient and how we can make sure people are more healthy, even as the continent gets grayer and the burden of NCDs increases. So before we get to that, though, a couple notes on housekeeping. So I encourage everyone to ask questions if you're online through the swap card platform. And for the people who are in here, you can look on your chair. There should be instructions to ask questions. And also, please do engage with social media on the hashtag Politico Healthcare. And we also have a poll for this session presented by our sponsor, Viatris. And the poll is, what is driving disparities in patient access to innovative therapies across Europe? And the options are reliance on overall survival data, different willingness of payment in different countries, lack of transparency, varied willingness or ability to adopt new pricing models or different HTA frameworks. So please do answer, and we'll go back to the poll at the end of the session. Now let me introduce our panelists. So with us, we have Lobna Salem. Thank you so much for joining us. Regional Chief Medical Officer, Developed Markets for Viatris. Joining us online, we have John F. Ryan, Director of Public Health at DG SANTE, Rui Medeiros, President of the Association of European Cancer Leagues, and Jennifer L. Baker, who's a member of the Executive Committee on the European Association for the Study of Obesity. So it's great to have you all with me today. I thought we could start out with a quick lightning round. If I could just ask the panelists to keep the responses short to a minute, and then we can dive in for longer responses after. So my first question is just, what do you see as the single biggest opportunity for the treatment of NCDs to emerge from the pandemic? And Lobna, maybe we can start with you.
Thank you so much. Thanks for being part of an esteemed panel. I think to understand, in order to solve the NCD kind of, I would say, burden in light of the pandemic, I think it's important to understand the facts. We all, from a directive perspective, understand that, treatment for NCDs in general has been delayed due to COVID. But in Viatris, we have conducted a survey on 4,500 patients where we looked into the impact on, on people living with NCD. We found that 50%, for example, their treatment was delayed. 54% had mental disabilities. 17% developed new cases, and more than 50% their conditions worsened. So it's not about being, feeling that, the conditions has worsened in NCD due to the focus on the pandemic, but we do have solid facts facts. So I think springing from these solid facts to develop real, concrete resolution and solutions, focusing on the private-public partnerships, I think it's crucial to solve the NCD pandemic, the NCD.
Great. Thanks so much. John, over to you next. Brief lightning question.
The same question?
Yes, the same one. Sorry, yes.
So I think it's quite clear that in the COVID pandemic, the normal operation of our health system is put under great pressure. I don't think I'm saying anything very original there. And therefore, I think your question about new treatments coming out as a result of COVID is not really where I see the issue as being. I think the issue is how can we make our health systems more resilient for such events in the future? And when I'm thinking about such events in the future, I'm thinking about things like antimicrobial resistance, but also structural issues, not treatment issues, but structural issues. For example, the increasing problems with workforces in some of our member states. So treatment is one aspect of the problem. Resilience of our health systems is another. And preparing our health systems to be more prepared for or more resilient in case of future threats of the same magnitude as the one we're facing at the moment.
Great. Thanks so much for that. Rui, over to you. Do you see any opportunities?
Yes, sure, for sure. I'm glad to be here. I'm not sure if all you know, ECL is a pan-European organization representing 30 cancer leagues. So I think we, as a workforce also on the field, we think we can help to in two ways. One, to understand the problem. So what was happening after the lockdown due to the COVID, and what the other part is, what can we learn with it? And the opportunities are out there. So we have to be ready for two ways. One, if a new wave comes, the other issue is to compensate the cases. For instance, in the case of cancer, we understand, and most of the researchers on the field and the entities, that at least 1 million cases were not diagnosed last year. So within all Europe, and around 100 million screening cancer tests were not done. So it's a huge amount of cases that can be and will have an indirect impact on the COVID-19 death toll. I think we have to learn what can be done. And the other thing is we as cancer leagues think we can be an independent force to help to learn the problem and to offer solutions to the community, because our members are in the field and are close to the patients.
Great. Thanks for that. Jennifer, do you see any opportunities emerging from the pandemic in terms of NCDs?
Right. Well, it's a pleasure to be here. I'm from the European Association for the Study of Obesity. And I'd like to remind everybody that obesity is a disease. The European Commission classified it as a chronic relapsing disease that is attributable to an abnormal accumulation or excessive accumulation of adipose or fat tissue. And from this perspective, I think from the pandemic, we've heard a lot about obesity. But if we look at it from the biology of the disease, we've really learned that we have to look at this beyond eat less, exercise more. It goes far deeper than that. So as we come out of the pandemic and we work to build back better, I think it's really important that we help focus evidence, research evidence that can be translated into policy. And to really fulfill this, actually, as EASO, we just launched recommendations about what's missing in the EU research agenda so that we can help put this forward and so that we can add to the resilience of the healthcare systems if we encounter this again. Because unfortunately, more than 60% of European adults are living with pre-obesity or obesity. So the scope of this chronic relapsing non-communicable disease is very large, and the impact that it has on health systems is also immense.
Great. Thanks so much for that, Jennifer. I want to return to the point of what policymakers can do about obesity in a second. But first, I would like to broach the subject of the cancer plan with John. I know that we have the action program for the cancer plan coming up. When can we expect that?
Well, what you're asking really, Carlos, I think is the implementation roadmap for the cancer plan. So we have a cancer plan adopted earlier this year. I point out that there were 2,000 contributions for adding and enriching the cancer plan. So it's a fairly consensual document, I would say. At least I hope so. But now we're at the stage where we're trying to define the timelines and who's responsible for which action. And that's what we call in Commission jargon a roadmap. And that's the next document which we hope to publish in the coming days, in fact. And that will really help people, I think, to understand who is doing what for each particular action. And at the same time, of course, we're also in parallel arranging for the financing of some of these actions. So if you look at the different financial actions that are financed under Horizon Europe, under the EU4Health program, or under other financial instruments, these are ongoing since July of this year.
So when you say in the coming days, can we expect that before the end of the week or next week?
I said the coming days, and that's what I meant. I mean, I don't put a day on it because you might be disappointed. On the other hand, if we publish before, you would be delighted. So I really don't want to say it's going to be Thursday or Friday. You know, I really can't say.
Sure. Okay. Thanks. Thanks for that.
May I add a point on this? Yes. Yes. May I add a point on this?
Of course. Yeah. Go ahead.
Yeah. Sure. I think what John Ryan has said is a very important issue, and as I told you, another point is now is essential to restore people confidence on the system, on the health system, on cancer screening and treatment. So we have to regain that confidence, and it's important to improve communication among stakeholders in order to ensure people are confident going to their regular checkups, appointments, and organized screening visit. In particular, coordinated information is to given cancer patients, both in high resource or low resource countries. We think, for instance, ECL cancer leagues have experience and an excellent work on field on that, and we can help on that. So it's another example where the European Beaten Cancer Plan can be improved.
Absolutely. We've heard from the civil society. I want to get the view of industry as well, Lobna. What do you make of Brussels' efforts so far with the cancer plan and with other NCDs as well? And how do you see yourself working with the Commission on these objectives? Absolutely.
I think there are two major efforts and hopefully, I would say, very deliberate plan. First of all, the EU Beat the Cancer Plan is no more, a priority. It's a necessity. Given the downstream impact, as we have seen now from, the lockdown on the NCD patients. So partnering definitely with the European Commission on that, that's very important, other multi-stakeholders. We also have a program with the European Commission on EIP, the EIP branch of the European Commission on healthy aging. People live longer, but not necessarily healthier. So we have those arms also. We have those two kind of priorities, I would say, from a European perspective. One other thing is that, as Viatris, we definitely look into not really cost cutting, but more of focusing on the portfolio, what we say, of biosimilars, which is really, in the last session, we were talking about quality medicines. Biosimilars are affordable quality medications that we can claim our expertise there. And we believe this is really providing a great opportunity from industry in general to our stakeholders and to the patients to have access to quality medicines, at the same time allowing governments and different, kind of national budgets to reallocate these resources into, from the savings perspective to infusion clinics, again, furthering the access even in a more meaningful way. since the introduction of biosimilars, just to give numbers, there has been $33 billion in savings since the introduction of biosimilars 15 years ago. Uptake of treatment for oncology patients, 26%. We're talking for neutropenic patients, which everybody knows it's a hindering factor for effective treatment and achieving, the outcomes needed, either overall survival or progression-free survival, by 100%. So definitely there's a great opportunity to provide patients with affordable quality medication, at the same time allowing governments to reinvest in the healthcare system to develop a resilient, sustainable healthcare system by reallocating resources in other areas where they can provide access to patients.
Great. We've been talking about cancer so far, but the panel is also about NCDs in general, which is why I'm really glad, Jennifer, that you're joining us today. Are there parts of the plan that you see as applying to obesity as well? I don't mean directly, of course. It's a plan very much focused on cancer, but are there ideas you can grab from there for policymakers? And would you like to see a similar plan at the European level for obesity?
Well, let's start with the easiest answer. Of course, it would be fantastic to have a similar plan at the European level. But if we do back up for a second, it's really important to remember that obesity is a gateway NCD, and obesity is linked with 13 forms of cancer. So if we prevent obesity or treat and manage obesity appropriately, we can prevent 20% of cancers. And we're talking about cancers such as those of the colorectal, of endometrium, the pancreas, liver, postmenopausal breast cancer. So these are cancers that affect a lot of people. So it was fantastic to see obesity incorporated into the plan. Of course, we'd like to see it go a bit further and actually consider the full continuum of obesity as a chronic disease. And I think going forward, that's our policy thought, that if we were actually able to incorporate this with the treatment and the management, and of course the prevention, but across a life course with different types of these treatments and management at different stages, because what works in one age group won't necessarily work in another. That's how we think that a really important impact be made upon, first, those people living with obesity, but also on the 230 other conditions that it relates to. So going forward, it really would be fantastic to see this incorporated as its own mission. And of course, we've created this recommendations about what's missing in the EU research agenda to help push this forward and to really identify how we can help translate this evidence into policy.
Jennifer, I
have a comment on this. Yes.
Absolutely, yeah.
Yes, we as ECL are disseminating the European Code Against Cancer, which is a guideline of 12 message that, and everything is out there, including the obesity. So it's in concordance with the Jennifer message. I totally agree that we have to deal on this as a general issue under prevention. And it is known if we, for instance, avoid obesity or control and avoid tobacco and that vaccination, around 40 to 50% of all cancers will be avoided, and also plus stroke, plus cardiac diseases, heart disease. So it's a win-win solution.
Absolutely.
I really agree with you, Riri. I'm really glad to hear you mention that. And it's really important to remember prevention, but also treatment and management of obesity.
Jennifer, I do want to press you on one point, which is, correct me if I'm wrong, but it seems like in the developed world, we only see obesity rates really going up. Now, I know that maybe policy making in this area is still somewhat young, but do we know what policy solutions actually make a difference? You were mentioning a report on evidence. Do we have evidence about what works on obesity? Because from what I know, some experts even disagree on what the causes of obesity are, that maybe it's not so much calories as it is chemicals that disrupt hormones. So I just wanted to get your take on that.
Well, that's a very challenging question. Of course, obesity is a very complex disease. It's not one etiology for every type of obesity. But I think what we do know is that we're not asking the right questions necessarily, because we're not always bringing it back to the biology. And if we took that perspective, I think some of these disagreements amongst people would go away. But of course, to translate this into policy, it's a long road, as we all know. But I think there's really good frameworks out there for how this could be done. For example, the Cancer Mission Plan. And as EASO, we're here willing to help and to really have this dialogue. So I think it's time to start talking about how we can take this from evidence to policy and really incorporating it into this idea of building back better with these resilient healthcare systems.
Sure. John, I want to bring the conversation over to you. I don't want to tie your hands with obesity necessarily, but just in the broader categories of NCDs, do you think it makes sense to have EU plans, or is this really something that just makes more sense for cancer for some reason?
Well, in terms of our general approach to non-communicable diseases, we use the Sustainable Development Goals as a framework. That's the first point, because all of our member states and the European Commission have signed up to the SDGs. And it's important as well, I think, to bear in mind that there are other determinants besides strictly health ones, which may have a relevance in changing health outcomes. Thinking here particularly of things like education, poverty, gender discrimination, and so on. So we like the SDGs from the point of view of the fact that they have a more integrated approach to objectives and an integrated approach to how to get to those targets. Secondly, we have taken the WHO disease-specific targets as a guideline as well. So putting the two together really gives us a good framework. And one of the points I'd like to mention is that the cancer plan is a bit of a spotlight. They call it a flagship, but it's a spotlight really. And it's putting a spotlight on a particular disease, which is obviously a major burden for our citizens in Europe. But at the same time, many of the actions in the cancer plan will also affect other communicable and non-communicable diseases. I'm thinking here, for example, of the actions that we have promised to undertake on nutrition, improving nutrition. If you think about the specific action on food in schools, increasing the consumption of fruit and vegetables in schools, increasing physical exercise, reducing harmful consumption of alcohol, and putting, moving levers like taxation or labeling as regards alcohol products. All the promises made on smoking. Can you imagine the impact that that's going to have if we can reduce, as we said in the target, and have a tobacco-free generation? These are all things which are in the cancer plan, which will have a major effect on other non-communicable diseases. And the final point I would make is we're not even in the area of non-communicable diseases only, because we have also targets in the plan as in relation to hepatitis and HPV vaccination, for instance. So all in all, I think the cancer plan has a focus, has a spotlight on a particular condition. But at the same time, it's going to influence a lot of non-communicable disease determinants as well.
Absolutely. And from what you're saying, John, it sounds like cancer is more than just about cancer, just like obesity is more than just about obesity. But Lobna, I want to go over to you. The conversation so far has really been centered around policy making and more prevention. But therapeutics is kind of where the rubber meets the road in medicine. Do you think there should be more of a focus on pharmacological interventions and, what drugs can do to help patients?
Absolutely. And before I go into the pharmacological, I think there needs to be a big part on prevention still. I mean, and we're talking about, we did with Viatris in partnership with the American College of Cardiology, NCD Alliance, as a representation from the civil society, World Heart Federation. What we call the NCD Academy is like educating healthcare professionals on how to tackle NCD, because in medical school, you don't deal with NCD as an entity, you deal with separate diseases. And that's a challenge because the patient does not come in silos, right? So even the guidelines lend themselves to kind of have the separate diseases, which in real world does not, it happens as comorbid. So that's one thing. So education for prevention and lifestyle changes are very important. When we come to the pharmacological treatment, definitely there are two aspects, as I spoke about. There are, pharmacological therapies like we're talking about biosimilars in oncology, for example. This kind of solves actually three problems: the access to patients, affordable, high quality. At the same time, give also incentives for manufacturers to innovate in this space, and I think this is very important. As I said, gives also an opportunity for governments to reinvest in the whole overall ecosystem to make it, healthcare ecosystem, to make it sustainable. So that's from a, kind of a biosimilars oncology. If you look at the NCDs in general, there are a lot of products that actually shape the guidelines, from a research perspective. These products are available, but also what we're talking about, value-added medicines. I mean, these are, either by repositioning, what we call like repurposing an older product that you can use for a new indication that was not approved based on such. You can do reformulation for allowing whole home care settings, especially in elderly. You can look into combination, especially with digital. And these are very important. The challenge that we face as industry is that there is no roadmap from a development and regulatory pathway that allows to kind of like invest and work on these kind of interventions. And this is not breakthrough, by the way. This is just incremental innovation. So this is going to benefit the patient. These products are out there. They are tried and tested and proven, the safety. So that's very important to kind of look holistically into the value-added medicines, which is a concept widely accepted, but I would say, I don't want to say poorly implemented, but definitely there's areas where we can benefit as a healthcare society really to look into ways and means for the value-added medicines to be realistically, especially also from the data perspective, implemented. Sometimes, manufacturers are asked for unrealistic data for this product kind of like age. So that needs to be really having a very open dialogue on that. And Viatris is part of the committee on the value-added medicines for Medicines for Europe, where we actually, work with industry and other healthcare stakeholders in order to provide solutions. But definitely, we're not there yet.
Absolutely. You mentioned biosimilars. Now, the cancer plan, one of the objectives of the cancer plan is this issue of inequality that we see in terms of statistics in different parts of Europe. Do you think biosimilars have a role in reducing these inequalities when pricing is an issue, for example?
Absolutely. As I mentioned, biosimilars, like since introduction, it saved $33 billion. We also have, like you look into Central East Europe, it's very different than the peers in other member states. So we found that, for example, the life expectancy in Central East Europe is really below, we talk about 65 years versus like other parts of Europe. So definitely having access to biosimilars across Europe is very important, but also educating patients on the biologic therapy in general, because that's one of the issues, because in Central East Europe, there is limited uptake even for biologics, that when you introduce biosimilars, there's not really the effective uptake in able to improve, to kind of reach the desired outcome. So I think education for patients, working with governments, and also making sure that, there's health equity as it relates to access across Europe.
Great. And Jennifer, cancer medicines have been one of biotechnologies and health sciences success stories in the past 10 years. We've seen a proliferation of different drugs, some of them extremely effective. We've seen generics and biosimilars also enter this space. In obesity, do you think we should be putting more efforts in finding treatments? The conversation usually revolves around prevention, and I'm sure that you don't want to get rid of that, but do you think there's also more space for treatment?
Absolutely. I mean, I agree with you. Prevention is always really important, but we really have to think about the disease onset and the progression of the disease. And this is where, of course, we need different treatment and management options, and pharmaceuticals certainly play a role. So it's neither one or the other, but of course it has to be there and it has to be incorporated. But I think it's just very important that it's this onset and progression of the disease that we really have to be thinking of obesity in this framework rather than just the prevention.
Great. Rui, I want to bring the conversation back to cancer away. He's just occupied with something. John, let me go over to you. I wanted to discuss the right to be forgotten, actually. This is something that is in the cancer plan under a slightly different name. I don't think it's actually called the right to be forgotten. Portugal has ratified this actually really recently. Do you think the Commission can push patients' rights in areas like the right to be forgotten to give us a more robust civil human rights framework for patients? And is that one of the objectives of the cancer plan?
Yeah, there is some reference to the right to be forgotten concept in the cancer plan. I think the idea really comes from several of these national initiatives. You referred to Portugal, but there are also some in the Benelux as well. And I think you're facing a situation really which is an effect of successful treatment, if I might say, that more and more people are surviving their cancers for longer. And therefore you have to live with this on your medical records and in your personal history. And the question is, how does this affect what many of us consider to be normal life? In other words, does it affect your right to buy a house, to take a loan, to get a new car and to finance it? All of these things which normally happen in somebody's life. And we don't really see that the fact that you had a diagnosis for a cancer and it was successfully treated means that you abandon then your financial rights for all the rest of your life. So really this is the challenge which we have. And I know that some colleagues in the European Parliament, some members of the European Parliament are proposing that we look at some of our financial legislation, the regulations governing financial operators. That may be one option, provided that we would be able to use that legal basis. Another option would be to actually seek agreement with insurers and with bankers in the form of a code of conduct or something like that. So I think the first problem is to identify the size of the issue which we're dealing with. In other words, is this an unusual issue? Is it a usual issue? Is it something which patients are confronted with systematically or occasionally? And this, I think, will give us a better idea of the proportionality of the response. And as I said, we're looking into all the possibilities which we have, whether they are financial instruments or codes of conduct, in order to propose a proper solution.
Great, perfect. I want to bring that over to you as well, Rio. We're discussing the issue of the right to be forgotten. Portugal recently ratified this, I think just last week. How important is this, and is this something the ECL is pushing for?
Yes, it is. It's a very good example what should be done, because it has implications, as John said, in insurance, and it's. I think we are on the right way. It should be done all over Europe. Among our ECL organizations, we have this discussion, and our proposal is to disseminate this proposal all over Europe. I think it's an important issue, the right to be forgotten, because it's a matter of citizenship and rights to be protected. So within ECL, we think it's a crucial thing to be done all over Europe. And the example of Portugal, I think, might be a very good example.
Excellent. I'm wary that we're getting to the end of our session. I just wanted to briefly mention the poll results because they're quite interesting, probably not tremendously surprising, but just as a reminder, the question was, what is primarily driving disparities in patient access to innovative therapies across Europe? And nearly half of respondents, 47%, said different willingness to pay in different countries. So yes, it is money. 33% said willingness to adapt to novel payment models. So that's also interesting. A minority said lack of transparency in HTA frameworks, and no respondent said overall survival data. So I don't know if anyone wants to weigh in on those results. Lobna, did you find that surprising at all?
Not at all. I think the classical or the conventional way of addressing what we say payment and affordability needs to change by pricing models, as well as we said, reallocating resources in an optimal fashion to allow for patient access and allowing to build a resilient and sustainable healthcare system. I think the overall survival data, this is why no surprise that nobody answered. All the data is out there, has a lot of good data on overall survival, progression-free survival. I'm not sure there's the lack of scientific evidence, but I think it's the payment models needs more refinement and willingness to do so. Great.
Well, on that note, I'd like to thank all the panelists for the really interesting discussion. And I would like to, thank everyone who came here for the first day of our POLITICO Healthcare Summit. We will meet you bright and early tomorrow morning at 8:55 for a discussion on the EU's vaccine diplomacy. It'll be moderated by my colleague Ashley Furlong. Next we have a networking cocktail. So for everyone who's here in person, please join us for a drink next door. Thank you.
Thank you so much. Bye-bye.